We are live in 5, 4, 3, 2, 1. We are live now.
Good evening to all our viewers of OrthoTV. A warm welcome to you all. We are here with the 9th episode of the second season of series on controversies and consensus in orthopedics, what we need to know. This series is being conducted bi-monthly every Wednesday evening with an interesting case presentation followed by discussion in each subspecialty of orthopedics. This season is dedicated to the young orthopedic surgeons having interest in each subspecialty of orthopedics with the goal of uniting skill with mastery, where the presentation is being moderated by an expert in that field. This platform is not only aimed at helping the young orthopedic surgeons to present their case and strengthen their communication skills, but also reach to a broader and more diverse audience through our OrthoTV channel, thereby increasing their visibility and exposure. This program is conducted under the chairmanship of Dr. Ashish Mohanty and Secretary Dr. Ashish Phadnis, Dr. Mrinal Sharma, Dr. Swapnil Keny, and myself, Dr. Deepak Gautam. Dr. Mohanty is the professor and unit head in the Department of Orthopaedics at St. Medical College and KM Hospital, Mumbai. He is an honorary consultant at Jaslok, Nanavati, and Sushrusha Hospital. He is the past president of Bombay Orthopedic Society, as an academician and a researcher. Today, we have three brilliant young orthopedic surgeons, one each in arthroplasty, one tumor, and sports medicine, with an expert panel including Dr. Vidyanand, Raut, Dr. Manit, and Dr. Nikhil. I would now like to call upon Dr. Mohanty sir to introduce our presenters and proceed with the session. Dr. Mohanty sir, all to you now.
Thank you, Deepak. Dear friends, greetings from Mumbai and welcome to the 9th episode of the second session of Controversies and Consensus in Orthopedics. It's a case discussion, based on different subspecialties. And as I was discussing that, I personally gain a lot from these case discussions to know each and every branch of orthopedics. Though I pursue arthroplasty, but I learn a lot. Similarly, we expect that you will learn a lot from these webinars. So now let me share the screen. Now the first case is going to be focused on the arthroplasty. And now we have Dr. Rajeshwar Singh Sidhu, who is a consultant in sports medicine and arthroplasty at Sidhu Hospital, Ludhiana, Punjab. He is fellowship trained in various hospitals in Canada and Bangalore in arthroplasty as well as sports medicine. He has many publications to his credit. He has also undergone many courses completed many courses in India and abroad. His passion also, besides orthopedics, he do social service activities as well as sports activities. Thank you, Dr. Sidhu, joining today and presenting your case. Now, we have our expert moderator, Dr. Vidyanand Raut, who is a KM Ortho alumni and his MS Ortho, D Ortho and DNB Ortho. Is a consultant orthopedic surgeon from Mumbai. He practices in various hospitals, especially from Andheri to Borivali. His special interest in arthroplasty, and he has done East Fellowships in Australia. He was a ROC Fellow, Ranawat Orthopedic Center Fellow, and is a Clears Fellow from Delhi. Welcome, Dr. Vidyanand Raut, to these episodes of Controversy and Consensus, and thank you for devoting time for the cause of academics.
Thank you.
Now I'll stop sharing the screen and request Dr. Sidhu to share his screen and present the case.
Thank you and good evening, everybody. Thank you, Mohanty sir and Dr. Deepak Gautam for giving this opportunity. Without taking any much time, I'll start my screen share. Okay, if everyone can see the slides, I'll start. So thank you again. Today I'll be presenting my case on total knee arthroplasty in multiplanar valgus deformity and the current evidence and why I chose a VVC constraint. I practice in rural Punjab in Doraha near Ludhiana. I was trained in Bangalore and was able to get opportunity to train further in Canada in hip and knee and shoulders at University of Calgary, at London, Ontario, and Alberta. So this is usually what we see anywhere in India, we get patients who come with advanced and neglected deformities. The level of complexity I was exposed to in North America and Canada was very different, but this is something, the neglected deformities, that's very native to our population. I'm sure if I'm seeing this in rural Punjab, we've all seen it in our practices if my friends in India and Southeast Asia are seeing. So very similar. So 62-year-old female, rural Punjab, homemaker, diabetic mellitus. She has this progressive valgus deformity since 15 years. Extremely apprehensive lady who, like most of the patients, sometimes we see some other patient in her community got a total knee that didn't work. She got so afraid that for 15 years, she's not been taking any treatment. It's not like she lives in a far-fetched area. Her son is well educated. They have decent land holding, so finances weren't really a concern, but just pure apprehension. And I'm sure a lot of us see this. So two things I want to show you here is we all can see the visible valgus deformity, but you can also see that she has a foot drop to begin with. And she didn't have any surgery before. She didn't have any accident or injury before. Probably the only reason we could come up was the progressive stretching. When we go further, we take x-rays. She has a valgus deformity. What we need to find out is what's the multiplanar deformity. So just a snapshot from when she turned in the sagittal plane, you can see she has about 5 degrees of hyperextension as well. So the number point, finding out that these are not just valgus, there is a coronal and sagittal component to it. And the coronal component of valgus always gets exaggerated when there's an associated sagittal plane deformity. The usual ones we need to look out for is hyperextension or recurvatum, like in this case, or usually a FFD. So a few things we also need to look when we see this patient in the clinic is what are the associated issues, what we can see just in our first glance. Evidence says that there are high chances of them having foot issues like planovalgus, and finding out what kind of neurological injury or issues they have pre-op. So these are the issues which I was consulted with. I do admit that I should have had long leg radiographs at this stage, but at that time our radiographs were having some upgrades. So this is what I had to begin with. But for academic purposes, I think it's very important that even if we don't have this in the beginning, in our pre-op plan, we have a proper skygram when we're dealing with this kind of deformity. So before we took her into OR, I was just wanted to see, does the MCL have an endpoint and how much correctable this is? So we can see that it's easily coming to about 35-40 degree to valgus. MCL did have an endpoint, but it was very lax. These kind of patients, I always do put a tourniquet, but I hardly ever inflate it. I just put it for an emergency, but I always make sure that it's high up because, and I'll speak about it further. So with this basic information to start with, this is what most of us in India always start with. We need to have pre-op planning. This is, and I know we all get to see very extreme varus knees. My colleagues will agree that a severe varus, which most of us treat, is very different from a severe valgus. And I'll speak as we go forward. I'll speak what I did, and I'm trying to present each rationale with an evidence that's always published in literature. So I would also suggest my young colleagues to take a picture of all the papers I have tried to present. These are landmark papers, and it's a moment of proudness for us that most of these papers are either from Dr. Ranawat or Dr. Arun Mullaji. So that's something to be cognizant of. So in my pre-op planning, I have always done this with a medial parapatellar approach. Because this was not a fixed valgus, I did not want to do a lateral parapatellar approach. It can be done. It's hard, but I did it with a medial parapatellar approach. With regard to what we need to be cognizant of with bony issues, and I'll speak further as well, but lateral femoral bone loss, proximal lateral tibial bone loss. With regard to ligament, we just saw how lax she was medially. We'll talk about what are the releases I did, and what are the evidences in literature. I'll talk a bit about why I did not do a lateral epicondylar osteotomy. And while planning, can we do this with a regular implant, or do we need to have a constraint or a hinge available? So if you remember, and I'll show this video again, but if you saw that lady walking, I don't think that we would be wrong in saying that hinges and CCK implants should be easily available in our OR. Unlike the West, most of us don't have these higher level constraints available in our OR readily. But if you plan them well, everything is available in every part of India, being rural or metropolitan. You just need to ask for it if you can see it. And evidence would say that all of these cases, in the best of their hands and whatever releases they do, can be dealt with all of these four options. I would actually never do it with a CR, but there are senior surgeons who would say they're able to do it. My options when I saw that lady was that I need to do it minimum to a minimum with a PS knee, and actually for a bad day have CCK and hinge available. I would recommend my colleagues to look up literature as well, and I suggest that this should be their thought process as well. I will be talking a bit about a newer kind of constraints, which is not new, but relatively new. That's a mid-level between the PS and the CCK. So just going quickly through classifications, Dr. Ranawat gave the original classification, but Dr. Mullaji, based on his navigation studies, has given us a more functional classification. I won't go too much into the literature, but just going basically that is the MCL intact or is it incompetent? And just like I said, is it a correctable valgus or not? And along with that, is there an associated hyperlaxity like a recovertum or a FFD along with that? So that was a basic classification. Goals of this landmark paper has been done by Dr. Ranawat, and this was published even before I was born. So gold level literature already exists on this. We just need to read it and review it. So my plan was to restore the mechanical axis. I do a conventional a time and tested conventional mechanical alignment knee for all my knees. My aim was to get it into the most neutral alignment possible, to maintain the joint line, to use the appropriate level constraint. I was ready from a PS to a hinge, and I do believe that the end goal is to give one surgery, and we have to give whatever gives the maximum stability. So everything was available. The other thing I was concerned was to give a good patellofemoral tracking. So for the recovertum deformity, what I did, as you can understand, though even I had a hinge available, I started with everything for a PS knee. For a recovertum deformity, we have to take a very bare minimum distal femoral cut. So at a minus level, where I was taking more bone medially versus laterally, and I've put in literature which supports that why you need to take a minimum cut for recovertum. For the valgus, the VCA, which is the valgus cut angle, literature has pros and cons for all three strategies. And these strategies are either you can do what Dr. Ranawat did, take a fixed angle, either a 3 or a 5 for all of your knees. The second is, that's why the importance of long leg skiagrams comes, that you measure the difference between the anatomical and the mechanical axis, and you choose a distal valgus cut angle accordingly. A gold level or a landmark paper by Dr. Mullaji, based on his navigation studies, does prove that navigation, if available to you, and you find out the correct valgus angle preoperatively, will give the best alignment possible. But again, there is evidence to support either of this. I went with what Dr. Ranawat's paper did. I took a fixed 3-degree valgus cut angle for my case. Going through just a few more steps, that's also important, and evidence proves this, because this lady had a hypoplastic posterior lateral femoral condyle. I was very cognizant while putting my 4-in-1 jig that I do not go into internal rotation. I dialed in a 5-degree external rotation. I did not use the posterior condylar axis because that can really put you in internal rotation. I used the transepicondylar axis. And I was very cognizant that I wanted to avoid internal rotation, and I dialed in a bit more external rotation so I get a grand piano sign as much as possible. That would help me with my rotation as well as patellar tracking. Now comes the important bit, releases. What I have learned is that laminar spreader is very important in that. Always use a cautery. The aim was to come out of an asymmetrical trapezoid gap and get it to a rectangular gap. So I used a laminar spreader. I know there's literature telling different sequences. It's everywhere. But what I did was that I wanted to first start with taking off what's been described in literature, start inside out. I removed the PCL, the posterior lateral capsule, and the IT band. I used a laminar spreader, and I know literature talks about taking a needle and pie crusting, but what I had learned in Canada was that you put a laminar spreader, feel for what is tight, and you sequentially and carefully with the cautery just remove while being cognizant of what you're removing till your laminar spreader gives you a proper rectangular gap. So after removing the PCL, the posterior lateral capsule, and the IT band, I was in a situation where my asymmetric gap had become symmetric. That is the stage where we start our balancing act and we see that can we put a PS knee or a VVC or a LCCK. So just giving you a quick overview that this is what Dr. Ranawat has recommended. Again, the aim is to first get out of an asymmetrical trapezoidal gap, reach a rectangular gap, and then see how much laxity you're giving. Sorry, I forgot to add that you have to check for that in the flexion as well. So I was well balanced in flexion, and I had eventually, after these 3 releases, come to a stage where I was rectangular. A very important study while you're doing this releases, and which was I was cognizant of, is after Dr. Ranawat had proposed his release strategy, they did another paper which found out where is the area which is the danger zone and which is the safe zone while you're doing your posterior lateral release so that you don't injure the nerve. So this is a very important paper I would recommend, my friends. And just a crux of it is that you should be cognizant where your popliteus is and your posterior band of the IT band is. Any place between this purple marked triangle is where you're most likely to injure the common peroneal nerve. Anywhere outside of this region, you can go boldly just like you would do for a varus knee. So being cognizant of this during a release is very important. And this is what I did, and this is what the paper supports. So once you have your flexion and extension gap balance, that is when you can try your starting level constraint. So I was in a situation where my gap was rectangular, but because of a lax MCL, I was very lax medially. Usually the mistake that happens is that we start, if we have not planned to upsize our constraint, you can just start increasing your poly size to meet up the laxity medially. But what that does is that overstuffs your joint. That can affect your range of motion as well. So the usual recommended evidence thing is to up the constraint. And traditionally, we all have used a conventional LCCK type implant. We all are aware of it, but just for my young resident and fellow colleagues, this is when we say that we are not happy with our PS level of constraint. You basically high up a constraint. You have to put a bigger box cut. What this LCCK type of constraint does is that the post of the poly is much longer and thicker. So the issue sometimes becomes is that our Indian females have a very small bone stock. This is what I realized when I worked in North America, was that we hardly ever saw small femurs, just like what we see in India, especially with females. Only when they were Indian patients or Asian patients, we would see small femurs. So when we're working with a small femur real estate, anywhere where we have to increase our bone cuts is always a thing that can give you some fear of future fractures, or you go beyond your concept of where you cannot preserve bone. So if you have to high up the constraint, LCCK is the only way, but there are newer level of constraints which I had used, which is called a VVC poly, just a varus valgus constraint poly. How is it different from a PS and a LCCK is that it's a mid-level constraint. You do not have to change your femur block. So the same PS knee for which you've taken the box cut, you don't need to put a traditional LCCK type femur where you have to increase the box cut. In that similar box, if you think you're not stable with a PS poly, the same femur and tibia will take this mid-level constraint, which is a thicker post, but it is not longer. Hence, it fits in the same bone. And this is a mid-level constraint where you can see that how stable you are. And if luck would have it, and as I had thought it would, the moment I just took out my PS poly and trialed it with my VVC poly, I was able to get good mediolateral stability, of which I was happy with. I did not have to increase the bone loss of my box cut to go to another level of constraint. So with all of these evidences and what I recommended, this was our end result. Just going through what we did. So for the femur, as you can see in AP lateral, I lateralized the component till I had bone. This was done so that I can get good patellar tracking. As you can see, unlike the LCCK kind of implant, there's no pin being seen there. So we were able to do this with a primary component. I would agree that the tibial stem was a bit of an overkill. Evidence now is there that if you're not progressing to a LCCK type constraint and doing a VVC constraint, the stresses are not that much and you do not need a stem. But I was always trained to put in a stem. Also, with an osteoporotic bone, I don't think there is any harm in putting it. So this is what we were able to get. I did not have to upsize the poly a bit. 8 was the starting for this lesion system. I had to put a 10, but with the VVC poly, I was able to get a neutral alignment. As you can see, I did not take too much tibial bone, it was minimum cuts, and we were able to get a neutral alignment for the lady. Few videos of her recovering. So day 2, as you can know, she hadn't walked properly for 15 years. Till the time she reached her 6-week mark, she was walking very well. You can see that medial thirst instability wasn't there. At 2 months, she's a simple lady. If this was North America, I would have shown you videos of people running marathons at 2 months, which people do, but our people don't have those expectations. She's a simple lady, simple homemaker. All she wanted was to be able to clean her kitchen in the end of the day, and she was able to do this. So I was very happy with this. Just a small point, I could have done a lateral epicondylar osteotomy as well. I personally did not do it because it's a small femur I'm dealing with. I have had experience doing it before, but the reason I put on this evidence is that usually when we talk about lateral epicondylar osteotomies, there's always sometimes a lot of confusion how to do it, where to fix it, and not. This evidence that was introduced to me by my boss in Calgary is a paper from Chile, and we had done this, is that you do your osteotomy, you start with a saw, you end it up with an osteome, but you keep the proximal soft tissue sleeve attached, and you do not fix the epicondylar osteotomy fragment. What it does is that it takes its position wherever it needs to do it. So this is a very good paper. The only indication they say is that you do it once you've done your extension releases and your flexion releases, and then also you feel that you're asymmetric in flexion and extension, because then when you do this osteotomy, you open up in flexion and extension, and your asymmetrical gap can become very symmetric. I have had this opportunity to do this in this case during fellowship. My boss, Dr. Kelly Johnson, was with me when we did it. And I won't deviate too much, but if you can see this post-op case, we did not fix this osteotomy in this case. It was a VVC poly, and I called him the other day, and the patient's been doing very well. So I was just trying to show that this can be done. I did not do it in my case in India because I was just concerned about the small femur size, but there is good evidence now that you can do it and you don't really need to fix it. One can take it with a grain of salt because a lot of evidences talk about fixing it as well. So this is what I did. So this is what my pre-op was. This is what the post-op was. The lady was happy. I was happy. I did learn a few things as well, that again, always good to pre-plan, always be cognizant that nerve injuries can happen post-op, but if they can happen pre-op, they can give you some confidence. Always have the right level of constraint available. And just a point on these, how these new mid-level constraints, similar that I use, the advantage, what I felt was that now they're easily available in India. The post-cam mechanism allows it to be used with the primary femur. You do not need to attach that pin kind of thing, and there's evidence to support they have good long-term outcome. Again, I would recommend that everyone have skyograms. We can really pick out whatever pathologies there can be up in the hip or in the ankle. End of the day, at 6 months, the lady was happy. I was happy, and thank you so much.
Thank you. Thank you, Dr. Sidhu. Actually, you took a little longer time. There's no time left for discussion now.
Oh, I'm sorry.
Just one or two questions before I hand over to Vidyanand. What did you do for foot drop? Did you evaluate preoperatively for that foot drop by EMG nerve connection study? What is the cause of foot drop? Because in valgus knee, before surgery, it's in valgus. So why the nerve will stretch out unless you take it, correct it, and then the patient develops foot drop? Or did you do a spine, MRI or something like that?
Yes, sir. So that was very odd, sir. As you can see, thank God there was video evidence that she had it pre-op. Otherwise, I would have
Yeah,
blamed myself in doing it. We did everything, sir, but no reason came out. The only that's why that was since she was so apprehensive in doing anything. Like I said, there was some relative who had a bad knee surgery. It was only his son who got her to get a surgery done forcefully,
okay.
but we did not get any positive reason for it. So even the only reason we could think of was that maybe it was extended, it was a stretched pre-op, I mean during this 15 years, but we could not find a conclusion to it, sir. So eventually I thought that maybe it was some neuropraxia because of some old injury, and when we even saw her at 1 year with this alignment, I thought maybe that would increase, but her status was the same. Unlike neuropraxia, which could have improved, her foot drop remained same. Like I said, for medical legal purposes, thankfully it was captured in the pre-op video, so we couldn't find a reason for it, sir. Yeah, sorry. And
Oh,
for her, yeah,
post-op, I would give a foot drop splint for him to walk better. Okay.
correct. We did that, sir.
Molded full drop splint which you give to these patients so their ground clearance is much better and they have a, you know, mimicking normal walking.
Correct, sir. So if the video you had seen where she's doing a chadu and cleaning, on one side she's wearing that foot drop splint. That is what I have given her. But even at the 1 year mark, her foot drop situation was how it was pre-op, and that remains a mystery to me.
Over to Vidya. Yeah.
Hi, Dr. Mohanty, and good evening, everybody. First of all, Dr. Sidhu, a very nice case, a difficult case to do, and a remarkable result. Having said that, I will give my thoughts on how I approach a severe valgus knee and what we do differently than a rather standard varus knee or a mild valgus knee. So, first of all, and I'm going to take a very little time, maybe not more than 4 or 5 minutes. So, I'm going to seem a bit rushed. Number one, approach. With a severe valgus like this, and especially if it's uncorrectable, doing it from a lateral approach, that is the lateral parapetal approach, is also a valid option. It's known as the Keblish approach, described by Peter Keblish. But as you said, the anatomy is different if you approach the knee from the lateral side. So even established surgeon, I'm sure Dr. Mohanty would agree, even severe valgus knee can be approached from the medial parapetal approach. And that's what you have done. So that's good. Secondly, the releases. So before considering the releases that you need to do on the lateral side, you need to see how much is the deformity correctable, both before surgery and after anesthesia. And you need to do those releases which are just required to correct that deformity. Obviously, on the medial side, you do nothing. You just dissect the bone up to the medial point. That's up to 3 o'clock position. You don't go into the posterior medial area in a valgus knee. In the lateral side, you feel what is tight and you need to release the IT band. Right. Now, IT band pie crusting is a technique which everyone must know. You have to feel with your finger what is tight in extension, and you have to do pie crusting. It can be done with a needle or a 50-number blade. You have to do it in a very graduated manner. Do some releases at the level of the tibial cut. Ensure that you're not damaging the nerve. In this case, the nerve was damaged already, but you have to be careful that your blade does not damage the nerve. And do the release in a gradual manner. See what correction you're getting. That's for extension. Sometimes you get a valgus in flexion. So you need to see what is causing that tightness. Sometimes you need to run the cautery or along the lateral and the posterolateral border of the bone to release the posterolateral complex. So that's as far as the releases go. The bone cuts, as you have done, a standard 3 degrees VCA that is valgus correction angle is standard in severe valgus knees. And I would also add a 1 degree varus tibial cut. This will also aid in getting the reduction. Then coming to constraint, now there are various levels of constraint, right from a uni to a CR knee. Within a CR knee, then we have a deep dish, we have all those lip liners and everything. Then we come to PS. In PS also we have after PS we have the ultra congruent knee. Between CR and PS we have the ultra congruent knee. After PS we have the PS plus poly, which is not readily available. Sometimes you get it in India. I think Smith and Nephew has it. So as you have done here, using the same primary femoral component, you can use the larger poly to achieve a stability. However, that's a compromise in my opinion, because in severe valgus knees like this, the post is under tremendous stress, and the patient is going to have that stress. Unless you correct the alignment completely, the post can break. So the post has to be fortified with a metal rod or something, and that can also only be done in a TC3 or a LCCK type construct, wherein there is a screw or a rod which gives strength and stability to the post, and that's called a varus valgus constrained insert. However, in this case, I feel not using a hinge is not a good idea, because see, today the medial side seems to be okay. She's walking, and I could see the videos of her immediately post-op. She's walking and doing all the household activities, but we don't know, we cannot trust the sleeve on the medial side. It can fail at any time. So in such a patient, we need to put a hinge. That's my personal opinion. I'm not saying that what you have done is wrong, but I would go one step further and I would put a hinge. And whenever we put a hinge, we are adding a lot of rigidity to the system. So we have to protect the hinge with stems on both sides. So we need a femoral stem as well as a tibial stem. Even when we use a varus valgus constrained knee, we should put stems ideally on both sides. Then you have mentioned about lateral epicondylar osteotomy. It's a very technically demanding procedure. And if it does not unite, if you're not able to fix it in small bones, in osteoporotic bones, it can be a problem. So unless you are experienced to do a lateral epicondylar osteotomy, you should not attempt that. Regarding femoral rotation, so you put a 5 degrees standard rotation and you did not use the hypoplastic posterior femoral condylar axis. That's the correct thing to do. But I would go with what Dr. Ranawat has always taught us. What we do is we use the cut tibial surface as a guide to how you place the rotation of the femoral block. So which means that we use a purely gap balancing technique, and we rotate the femoral block to make it parallel with the already cut tibial surface. This is how we achieve the balance in flexion. The last point I want to mention is the nerve care. If the nerve was intact before surgery, and if you find a nerve weakness post-operatively, you have to be very careful. Keep the knee flexed, keep a pillow under the knee, investigate, and sometimes the palsy disappears, but sometimes it persists, and then you have to investigate with the help of a nerve conduction study and find out what is the cause. Neurolysis is generally not required. I think I've covered all the different points. Maybe Dr. Mohanty can add a few points. Sir?
No, all everything you have covered. Thank you very much. And as you told rightly, right now in Smith and Nephew system, only this PS plus and higher constant liners, inserts are available with the primary implant. So what Roger has done, that he has taken the advantage of that lesion knee, that putting a constant insert there. That's, I think, is okay. And a great job done. Thank you very much, Roger. Thank you, Vidya, for a
Thank you,
great
sir.
discussion. Let us
Thank you
move
for
ahead
those
with the.
points, sir. Yes, sir. Dr. Raut, I would agree with most of your points, sir. Just hinge was available, but at 62, and with my construct being stable, I did not choose a hinge at 62.
No. I'm not denying what you're saying. What you did was wrong. It was good. It was good.
Let us move ahead with the next case. Due to constraint of time, we have 2 more cases to go. We can always have a discussion later on. So friends, let us move ahead with the next case. It's from, it is from the bone tumor. And we have Dr. Deepak Garg with us today to present the case. He's a consultant orthopedic oncologist at Delhi Heart Institute of and Multispeciality Hospital, Batinda, Punjab. He has his fellowship trained at Rajiv Gandhi Cancer Institute, Delhi, and his interest is complex tumor reconstructions and megaprosthesis, soft tissue sarcomas, and arthroplasty. And we have our moderator today, Dr. Manit Gundavda, who's a consultant orthopedic oncology and bone soft tissue tumors at Kokilaben Dhirubhai Ambani Hospital in Mumbai. He has experience of an orthopedic oncology from Hinduja Hospital for 5 years before this. And Dr. Manit had done his clinical fellowship in musculoskeletal oncology from Toronto, Canada, Mumbai, India, and visiting clinical and UICC technical fellowship from Birmingham, UK. And he has experience and interest in cutting edge navigation guided and patient specific 3D tumor surgery. Thank you, Dr. Manit, joining today for the cause of academics. Now
Thank you for having us.
Now I hand over to Dr. Deepak to present his case. You can share your screen, Deepak.
Thank you, sir. Thank you, OrthoTV team. Thank you, Deepak Gautam sir, Mohanty sir, for giving me this opportunity.
Play. Yeah.
So, sir, this is a case of distal femur undifferentiated sarcoma. I will be emphasizing on the role of the pre-operative biopsy scar in the.
Can you make a full screen? It's not coming full screen.
So this is a full screen, sir, on my PC, sir.
All of you are able to see full screen? Dr. Manit, you are able to see full screen?
I can see the slides on the left and the transitions on the right.
Yeah. Okay. Just if you can close and do it again, because it's
Okay,
not
sir.
full screen.
So is it full screen now, sir?
No.
I'll
No,
stop
it's
sharing
the same, I think.
and
Just
then I'll again share it.
you can stop your video if the net is.
Mhm. Sir, is it okay now, sir?
Not really. Okay, you don't do full screen as at least from that screen you can run it. Go back. You can go back. Yeah, just okay. Now make it.
Okay, sir.
Now you can share and you can just present it like that rather than making it full screen.
Okay, sir.
That will be better. Yeah. Now okay. You can say. Yeah. Don't go into presentation mode. Then it hangs up. There is some problem.
Okay, sir. Only in this format, sir?
Yeah.
Yeah, we can see it. We can cut it.
Yeah. Yeah. Good. Yeah. Great. Now it's okay.
Okay, sir. So this is a case of a distal femur undifferentiated sarcoma. I will be emphasizing on the role of the pre-operative biopsy scar in the final sarcoma surgery, sir. So this was a case of 33-year-old female patient presented to the OPD with a pain swelling in the right lower thigh. She was a known case of biopsy proven non-metastatic undifferentiated sarcoma, right distal femur with completed 3 cycles of neoadjuvant chemotherapy elsewhere. So patient presented to us in this with this uh, biopsy scar on the anteromedial aspect of the distal thigh. This was a 6 centimeter vertical biopsy scar mark on the anteromedial aspect of the left knee. So this is not a usual biopsy scar that we get. The usual biopsy scar is so there are animations which are not visible because I cannot make it up on the presentation user. So usually when we take a biopsy scar, we take with the 8 gauge J needle, and with the 8 gauge J needle, we usually give a nick of around 0.5 to 1 centimeter, and we get a sample like this. So this is not a usual biopsy scar. Whenever we get a patient with a already done biopsy somewhere else and we get a biopsy scar which is not usual, then the first question that we get in our mind is limb salvage versus case. So if we
I'm not able to hear him.
I think it's left.
So considering the example of this apple, so
Deepak, could you make your you switch your video off, because there is a net is poor, so here sometimes your voice is breaking. No, your video, own video. You can
okay, sir.
stop video. Yeah.
The video just presented.
Lower left-hand corner, stop video in the Zoom.
Yes.
We'll have to stop the Zoom video. Yeah.
Yes, sir.
Go ahead.
Go ahead. Yeah.
So to understand this, we take an example of this apple. So this example is written from the corners. So first we in the MRI will define define the tumor, and then we should have a margin around the tumor. So this gap is a margin. This is a normal cuff of the normal tissue. So if we talk about the bone, we should have a margin of around 2 to 3 centimeter. And if we can take, we should have a margin of the muscle in the soft tissue, and the barriers like physis, periosteum, and thick fascia will act as a margin. If the neurovascular are closed, then we will have to sacrifice the neurovascular bundle sheath, and that will act as a margin. So we can think of limb salvage surgery only if we can achieve the wide margins. So taking this case, let's investigate this case. These are the plain radiographs. So we can see that in the distal femur, we can see subtle lesions. These are subtle moth-eaten kind of appearances. So we get the further contrast MRI. In the contrast MRI, even here, there is a lesion in the distal femur, and this is involving the metaphysis and the epiphysis area. This is not involving the joint, and there is a large soft tissue component. Similarly, on we can see that there is a large soft tissue component with the femur involved, and so for the pre-operative planning, I have made these templates. So this is a normal anatomy of our thigh. We can see the various muscles and their relation with the neurovascular. The usually
I think he has net issues. We're not able to hear him. Can you just let us know what you have done?
Looking at this involved sacrifice the vastus intermedius muscle in out. But if we want
Your screen stopped, Dr. Deepak. Could you quickly show us what you did? We are not able to hear. Are you able to hear anybody?
No,
but
we can't hear.
we can see the pictorial diagram what he has
Yeah.
shown. Then we can
Yeah.
take it for the discussion. No issue, sir. Let
Yeah.
him go. I think Dr. Manit can make it
Yeah,
up
yeah.
after going through. Okay.
Dr. Manit can, you know,
Okay. So
So this is a very clear case of what should not be done for bone tumor. So there's a massive tumor which has been identified, and firstly, we don't have any pre-biopsy imaging, which was possibly not available or inadequately imaged before the biopsy. And after that, today, in today's technology, today's access to a good pathology, there is no role of an open biopsy. A needle biopsy, as Dr. Deepak has shown, with a J needle, with a stab incision, through the correct approach, which should ideally be only medial or lateral, is adequate to give us good enough tissue. And again, the diagnosis of an undifferentiated sarcoma is again unusual. Further molecular tests are available to identify what kind of sarcoma that is, because that will also help us to understand what kind of neoadjuvant chemotherapy should be given. Is it like a round cell Ewing sarcoma chemotherapy versus an osteosarcoma protocol? And response to chemotherapy is extremely important to assess whether this patient goes for an amputation or a limb salvage procedure. So as I can see, they've done a modified approach to excise the biopsy scar site. And
Manit,
if he's back, he can.
do you do a staging before surgery?
Absolutely.
Yeah.
So absolutely. A PET CT is an
PET CT,
absolute.
yeah.
So
That's
local imaging and systemic staging, those are two things which always have to be done if this is a sarcoma.
Mm. And in this particular case, they have salvaged the tumor. Suppose you do a salvaging surgery, then what you do?
So looks like they've done a salvage here, but I'm skeptical considering they've gone anteriorly. I'm sure at some point they have interfered with the suprapatellar pouch, so a modified extra-articular resection is possible. The posterior structures we assume are not involved or affected since the biopsy is anterior, and as I can see, they've ellipsed the biopsy tract. There's a good muscle cover over the tumor. What they're dissecting right now is the posterior feeders to the tumor, and the vessels look like they've fallen behind. So it's somewhat of an extra-articular attempt that has been done, which looks acceptable margins wise on the photo that I can see. But like I said, opinion with the orthopedic oncosurgeon today, we are just a phone call away. Just WhatsApp your friends and ask where to biopsy from, how to biopsy from. I'm sure all patients cannot travel to an onco center, but just send an X-ray to your closest ortho onco guy and ask him how to biopsy and where to biopsy from, and that saves a lot of important muscle which is required for these mega prosthetic reconstructions to last longer, because that is what is going to give the stability, the inherent stability, how the patient walks. We're putting in a mega prosthesis which is just bone reconstruction, but if there is no quadriceps mechanism, like this patient has lost so much quadriceps only because a lot of biopsy scar had to be excised for tumor excision, and that will clearly compromise the overall extension of the patient.
Correct. And post-operative, continue.
We can see the neurovascular bundle in that photo there.
Yeah.
As we can see, all of the skin is a part of the biopsy tract. You can see a lot of muscle which is covering the biopsy tract. So all of that has been removed as margins. Again, in the suprapatellar region, like you can see, there's like a very thin film of just the synovium, which is covering the tumor, which is generally acceptable if you've not violated the planes. And it looks intact in this. So it's a very well achieved margins, I would say. For given the setting, this has been adequately resected for a patient if there has been some good response to chemotherapy. That would be my main indicator to offer this to a patient.
Yeah.
And we can see a mega prosthetic reconstruction. Dr. Gautam, if he's back, he can take it from here.
Yeah.
If not, I can run through.
Dr. Deepak, Are you there?
Me?
Dr. Garg.
No, Dr. Garg.
Yeah, I think he's moving ahead. You can
Acha,
show
okay.
the final photograph and any
Yeah.
chemical things. Yeah,
So
good.
as you can see here, there's a lot of vastus
Oh,
missing. It's a very makeshift incision. There's going to be a affection of the extensor mechanism.
Mhm.
But in the end, as long as the tumor is out, that would be the real achievement for the patient to achieve R0 resection, which is negative margins.
Mhm.
In a patient which has been violated in the wrong planes, that would be the real achievement. So the margins are, as we can
Free,
see,
free of tumor. Yeah, that's
free
right.
of tumor and centimeters. But in short, this is extremely good for the tumor clearance. But we have to also note that all of these margins are basically good muscles which could have been preserved for the patient. So
Yeah.
doing a needle biopsy through the medial or the lateral approach, through the correct principles, like I said, we're all just a phone call or a WhatsApp away, and that's all it requires.
Yeah. And do you give post-op chemotherapy?
Absolutely. So all sarcoma patients, bone sarcomas, there are basically only three types of sarcomas: osteosarcoma, Ewing sarcoma, and chondrosarcoma. Chondrosarcoma has no neoadjuvant, no adjuvant therapy. But Ewing sarcoma and osteosarcoma, more than the surgery, what is important is the chemotherapy. So neoadjuvant chemotherapy, you assess the response, you tailor your plan, surgical plan according to the response, and then all of them require adjuvant chemotherapy, Ewing's as well as osteosarcoma. So undifferentiated sarcoma is ultimately, like I said, higher studies at some point required to assess whether you're treating it as a round cell Ewing's or as an osteoid forming osteosarcoma protocol. Because the chemotherapy protocols are made according to those two broad diagnoses.
I think mine was muted by mistake, I think.
Okay.
Am I audible, sir,
But
now?
no issues. We have seen your X-rays. We have seen all these things. Just have some discussion. Dr.
Yes, sir.
Manit will just discussing. He only described whatever you had shown. Okay.
Yes, sir.
Okay.
Dr. Manit sir rightly said that this was just a case to show that biopsy is a very prime importance in the final sarcoma surgery. Sometimes we have to go for the amputations just because there are the wrong biopsy tracks on the wrong biopsy sites.
Right now, they don't give any radiotherapy to Ewing sarcoma. Previously, it was given whatever we have
So,
read.
Sir,
so radiotherapy for Ewing sarcoma alone is inferior to surgery plus radiotherapy. So there's enough data to say you get R0 negative margin resection, and then you add it up with radiotherapy. But radiotherapy alone is reserved for unresectable sites somewhere in the sacrum, spine, or a very morbid pelvis.
Okay.
or where we think we will not be able to achieve the safe margins.
Yeah. Okay. So Ewing sarcoma nowadays you give surgery plus radiotherapy and plus chemo also.
Plus chemo.
Plus chemo. Okay. Mm-hmm.
Like I said,
Now,
chemo has to be that is the mainstay.
yeah.
Because that is controlling the systemic disease, preventing the mets. That is the keystone.
Dr. Deepak, what prosthesis you have used this one?
XLO, sir.
Sorry?
XLO, sir. XLO.
XLO, sir. Which company is this?
XLO, sir. XLO.
XLO.
XLO is an Indian mega prosthesis manufacturer. They have the armamentarium to make custom prosthesis as well.
Okay.
I think they also have a rotating hinge.
Yes.
The only drawback is the articulating component is either stainless steel or titanium, as opposed to the international companies which would give you cobalt chrome. So
World chromalum. Yeah.
But there
that
is
is the
huge
only hesitation. But it gives you a mega prosthesis at a cost which is sometimes even cheaper than a primary knee. So I'm sure it's a very well loved implant for its cost.
And number two, the plastic and bushings which they give, those are also they were of much earlier. That is one of the disadvantages which in Indian mega prosthesis now we found it difficult.
Yes, sir.
However, I like to make a point
Yeah.
These patients are usually from a lower socioeconomic class, and they have already spent a lot in the previous surgeries. So, offering them something, an Indian solution at a cheaper rate, I think that's the way to go. The Indian
Absolutely.
implants need to improve further, but I mean, the cost difference between the Indian and the imported versions is too great, simply too great.
Is
Yes.
massive. And we are actually I've been part of a clinical trial with Dr. Manish Agarwal for the NFTDC implant, which is being manufactured in Hyderabad. We're close to 100 implantations already, and hopefully that is an international grade implant which is manufactured at a government body, and we would assume that the cost would be very competitive and easily affordable for a patient. That's going to be a rotating hinge, that's going to have a cobalt chrome articulating component, and that's going to have international level poly put into an Indian implant.
Okay.
So I think that's a matter of time now.
Mm-hmm. But great case. Nice, discussion. Thank you, Dr.
And patient has to spend a lot on chemotherapy also.
Yeah,
So, and
yeah,
patient will come to us after the chemo.
yeah. How many years follow-up now? This is or
So
recently
this was
done?
just 15 days back, sir.
15 days back. Okay, great. So we need to see the follow-ups also that for the recurrence
Yes,
and
sir.
for the function of this patient.
So I think the take
Yes.
home would be local and systemic staging, and just do a correct biopsy.
Yeah.
Just talk to your friends and get the approach, and a needle biopsy. There's no role for an open biopsy today. If with a
Okay.
needle, with a good biopsy, you can get adequate tissue.
Okay. Great. Thank you. Thank you, Dr. Deepak Garg. Thank you, Dr. Manit, for
Thank
a
you.
lot of take-home, points from that case. Now, friends, let us move on to the last case today, which is, focused on the sports medicine. And let me introduce our speaker today, Dr. Shradha Anil Kulkarni. Dr. Shradha is a MBBS, MS and DNB Ortho. She is MS from Bombay Hospital Institute of Medical Sciences. And at present, she is a clinical fellow with Dr. Hetal Chiniwala at Bombay Hospital. Prior to this, she has a short stint at 6 months at BNSI Hospital. She has presented papers and posters at various national and international conferences and winner in paper and poster presentation of the gold session in Ishikan 2022. Thank you, Dr. Shradha, for joining today and presenting your case. Now to moderate this, we have Dr. Nikhil Gokhale, who is again our KM Ortho alumni. Dr. Nikhil is a FRCS in Trauma and Orthopedics and done his MRCS in Edinburgh and is a diploma in computer assisted orthopedic surgery. Dr. Nikhil is a consultant shoulder and knee surgeon practicing in various hospitals in Mumbai. He has done his knee fellowship from Exeter Knee Unit and joint reconstruction fellowship from Royal National Orthopedic Hospital, Stanmore, and his shoulder fellowship from Royal Bournemouth Hospital. Thank you, Dr. Nikhil, joining here today.
Thank you, sir. Thank you for the invitation.
Now I stop sharing a screen and request Dr. Shradha to share her screen to present the case. Let's move to the first slide.
Yes, sir. Thank you, sir, for the lovely introduction. Good evening to all. I'm Dr. Shradha Kulkarni, and today I'm going to talk about two such cases that came with a recalcitrant fixed flexion deformity of the knee to us in the recent 3 months, and how we approach these cases and manage these cases so that the patients had a wonderful surgical outcome. The first case is a 44-year-old female who presented to us on the 28th of June with complaints of pain over her right knee and inability to fully extend her knee since 1 month. There was no recent history of trauma or fall preceding this injury, except last year in September 2023, she had a fall with a twisting injury while walking on an uneven surface, which was treated conservatively in her hometown in Chhattisgarh with a plaster for 20 days. She alleges that after removal of the plaster, she had intermittent pain over her knee while walking, but she had no restriction of movement. On clinical examination on presentation to us, she had an effusion. She had a fixed flexion deformity of 40 degrees with painful flexion up to 90 degrees and pain on any attempts on active or passive extension of the knee. This was our MRI, which we had done on the 12th of June. Now, in this MRI, you can see on the T1 imaging that there is a well-defined discrete lesion anterior to the PCL, which is displacing the fibers of the PCL posteriorly. On T2 images, you can see that it is hyperintense and it is present anteriorly, displacing the ACL a little laterally. Once we had given a spinal anesthesia and the pain had worn off, her leg could be extended completely and there was no flexion deformity which was residual. On ligament testing, it was found that her anterior cruciate and her posterior cruciate were found to be intact and there was no crepitus or any bony block on movement of her knee under anesthesia. This was the Scopy video intra. As you can see, there's a huge cyst in the intercondylar region, which is discrete. It is not adherent to the ACL. It is anterior to the PCL, obscuring the PCL almost. The ACL is found to be intact. Once we had defined the margins, we started puncturing the cyst and we started taking biopsies for histopathological examination. When we started puncturing, you could see the cyst material sort of coming out. And on further core biopsies that we took, we found that this was arising from the posterior bundle of the PCL, pushing the rest of the intact PCL fibers posteriorly. So this was the footprint of the cyst. On the posterior insertion on the femoral side, the PCL fibers, the remnant PCL fibers were found to be intact and she had no posterior translation. These were the images of the cyst. As you can see, huge lobulated discrete cyst, which was not locally invasive. It wasn't invading the surrounding structures, the ACL, nor was it invading the bone. Now, what could this be? Considering that her age was 44 years, it could be because of mucoid degeneration and a cyst form because of the mucoid degeneration of the PCL. Considering the trauma history, it could be a ganglion cyst of the PCL. Rest of the differential diagnosis are slowly marked out as it was found to be arising from the posterior bundle of the PCL in itself. The one diagnosis which we needed to exclude only on the matter of the histopathological examination was a tenosynovial giant cell tumor. Now, post-operatively, since we had achieved full range of motion, we started with aggressive mobilization, closed chain knee range of motion, vastus medialis strengthening, and full weight bearing mobilization with a walker. Finally, the histopathology report arrived and it showed a cellular fibrocartilaginous tissue with focal myxoid change and ischemic necrosis. Now, on 2 months follow-up, you can see that she has achieved full range of motion, no extension lag, no flexion deformity, and she is walking pain-free without any assistance. Now we go on to the second case. In this case, we have a 33-year-old active male who had a fall from his bike 1 month prior to presentation. His chief complaints were that he had pain over the knee while walking and he wasn't able to extend his knee fully. On examination, we found that he had a 10-degree flexion deformity and further flexion up to 120 degrees, which was painless. Only any attempts on extension, active or passive, were painful. These were his MRI images that I have put down. Here you can see that there is a small cyst. On the T2 image, it is hyperintense. You can see it arising almost from the tibial footprint of the ACL, anterior to the ACL. And on T1 images, it is found to be hypointense. This was the intra-op video. As you can see, this seems to be arising from the anteromedial footprint on the tibial insertion. Again, 1 month history of trauma. We started shaving it off, clearing off the cyst and its contents until we saw the linear parallel arrangement of the ACL fibers. Once this was done and we were sure that the cyst was completely removed, we probed the ACL and we also did an anterior draw test under Scopy visualization to check the integrity of the ACL so that we could start mobilization post-operatively. Now, why was movement restricted in both of these cases? There was a brilliant paper by Dr. Triantafilidi et al. That demonstrated that the PCL occupied a significant portion of the notch during flexion. Meanwhile, the ACL occupied more volume in extension. In the diagram below, you can see that the blue line is the ACL and the red line is the PCL. Now, in the first case, as you could see, that there was a cyst that was occupying the intercondylar notch anteriorly, arising from the posterior bundle of the PCL, which was impinging while the patient was trying to extend her knee. In the second case, you could see that the cyst was arising from the tibial insertion of the ACL, or arising from the anteromedial bundle, and it was impinging and causing pain to the patient on the terminal extension of 10 degrees. Here we can see the Bergen's criteria for ACL cysts. So now the coincidence that ACL and mucoid degeneration cyst can occur together is very rare, but there have been reported cases with a 35-degree incidence of ACL cyst found to be of mixed origin. So when you go to differentiate these on MRI examination, you can confidently use the Bergen's criteria, which states that in a ganglion cyst, there should be a fluid signal in the substance, there should be a mass effect displacing the cruciate, and there should be a ligament signal which is stronger than the joint fluid with definite margins. In mucoid degeneration, the ligament fibers are poorly seen in T1 while they are better seen in T2 imaging. But the common criteria that suggests that these are cysts are ACL fibers are intact from the femoral to the tibial insertion, and they are possibly associated with joint effusion as we saw in the first case, or bony cysts. Now, what causes these post-traumatic cysts? There are many controversial theories, and the etiopathogenesis is not worldwide accepted, but there are some theories that have been accepted as the most probable cause, which are frequently attributed to a traumatic event. The most commonly accepted theory is post-traumatic mucinous degeneration of the connective tissue mediated by the local release of hyaluronic acid. The second is synovial herniation during embryogenesis and mucoid degeneration, which of course occurs with age. All of these mechanisms together or singularly result in the formation of a non-epithelial layer which accumulates fluid from the joint or the tendon sheet, hence forming a cyst. One little tidbit of information which I wanted to share is what causes these ACL and PCL injuries and why notch index and the notch width is important in trying to quantify these injuries. Now, there's an increased risk of ACL injuries, as we know, in intercondylar notch stenosis, but also there is a larger inner angle of the lateral femoral condyle in these cases, which causes impingement of the ACL and valgus internal rotation and an increased risk of ACL injury with patients with a narrow notch, especially in women where the notch width index is found to be narrower compared to males. Now, also considering PCL, increased risk of PCL injuries are seen, again, not stenosis, but also with a smaller posterior tibial slope, a lower intercondylar notch angle, and a larger posterior femoral condyle, which causes increased stresses on the PCL. Now, one very important thing is a narrower notch means smaller volumes of the ACL and PCL, ergo, they are at a higher risk for injury once the patient has a traumatic event. In conclusion, I would like to say that the cysts at the ACL and PCL are formed after trauma. The etiopathogenesis is not widely accepted, but we can only speculate from whatever information we have. The mean age for developing ganglion cysts is 39 years, and for mucoid cysts is 43 years. The investigation of choice is an MRI, and the gold standard treatment is arthroscopic excision of the cyst. Post-operatively aggressive mobilization and strengthening, and the rate of recurrence in literature has been found to be very low with excellent outcomes. All in all, it is a no risk, you could say high reward and highly rewarding surgery to the patient and the surgeon as well, with early return to daily activities and a good functional outcome. Thank you to everyone, and a special thank you to Dr. Hetal Chiniwala sir as well.
Thank you, Shradha. That was an excellent, very crisp presentation along with the literature review. So what was the biopsy report?
So the biopsy report showed that there was fibrocollagenous material with myxoid changes in the cyst as well as focal ischemic necrosis.
Both the cases?
in the first case, that was the report. In the second case, we did not take a histopathology sample because we were sure that this was a definite ganglion cyst. So that was one of the drawbacks of the second case. But the first case, we were very sure that we needed a histopathology diagnosis as the cyst was quite large.
It's always post-traumatic and not any disease conditions like, say, tuberculosis or anything can give rise to this kind of cyst.
So these kind of cysts, when we see that there is a loss of the synovial lining, along with age-related changes to the notch, as well as the cruciates with newly deposit glycosaminoglycans and loss of the collagen fibrils. This is when the cyst develops, when there is a trauma added to all of these effects on the cruciates.
Okay.
So,
Over to Nikhil, yeah.
Yes, nicely presented and excellent outcome. And these patients, essentially, when you look at stiff knee or in fact any stiff joint, I think the way to think about it is whether it's an extra-articular problem which is causing stiffness or intra-articular problem. And if intra-articular, whether is it a bony problem or a soft tissue problem. My one question, in fact, to Manit is that looking at the scans of the first patient, I mean, I would have, and Manit practices near me, so I discuss a lot of my patients with him. I would have discussed this patient with an orthopedic surgeon. I mean, it came out to be benign, and most probably it was going to be benign. But in fact, we have discussed a similar patient, if you remember, Manit. So I would involve, at least an opinion of a onco surgeon in the first case. In the second case, yes, it was pretty much evident on the scan that it was more like a benign pathology. Also, the amount of stiffness that the first patient had, say, patient had about 40 degrees of flexion deformity and a lot of pain. So I would have involved somebody like Manit. What do you feel, Manit?
Well, in fact, you asked me the question that I was going to send towards you. That, I mean, somewhere in the differentials, you had synovial sarcoma, you had TGCT as your differentials, and I mean, what really do we do? Is a good MRI or a good radiologist who is reading the MRI good enough for all the knee surgeons, or do we, jump to the next step, which is like a contrast MRI, a pre-op biopsy? So, I mean, if the panel tells me that a good MRI with a good radiologist reading the MRI is good enough, then I take it. Otherwise, I would have added a contrast MRI, just make sure what it is. If it's a cyst, it's not going to take up the contrast, and it's a very small addition to an already MRI which has been performed for the patient.
Yes.
So what does the panel feel?
No,
So I think in today's day and age, if there is any suspicion of it not being benign, then it is definitely advisable to investigate more, take an opinion of a specialist, and cover all your bases.
My question to Manit is, have you seen cysts like this presenting, diagnosed to be a synovial sarcoma?
So synovial sarcoma is basically a misnomer. It has nothing to do with the synovial lining, but intra-articular tumors are common. Nodular tenosynovial giant cell tumor is common. Tenosynovial giant cell tumor can be malignant in rare cases. So if that, looking at the size, looking at the presentation, if it's only a degenerative thing, it looks quite significant. And like I said, a simple MRI will tell you cyst versus no cyst. If it's taking up contrast, it's a solid cellular lesion, and certainly would help, do the specific sequences. You can add a diffusion gradient sequence, you can add a diffusion sequence, you can add a contrast. It's extremely challenging to biopsy an intra-articular tumor because you're violating the joint space anyways. But just doing a good MR with a tumor sequence protocol and adding a contrast will give you a lot of information if the radiologist is doing a lot of joints as well as tumors and they know what they're looking for.
Yeah. So it's a very rewarding surgery. Means in terms of patient's satisfaction outcome.
Immediate outcome.
Immediate outcome. Yeah. So what is the rate of recurrence of this cysts, the degenerative cyst? Do they recur very often? What does the literature say, Shradha?
So the literature search that I did, it showed that there was almost no to low recurrence of this cyst. Once we remove the cyst in toto and we ablate the edges of the cyst, the rate of recurrence is almost nil.
Do you do some kind of, burn the cyst wall with your,
Yes, sir. So we used an ablator, a cool cut ablator, and we had ablated the cyst walls, the remnants that we had found on the ACL and PCL after checking the integrity of the ligaments for sure.
Okay. Nikhil, any other thing if you want to
I think
discuss?
a lot of the, to be honest, unfortunately, we see a lot of patients who have knee pain otherwise in their mid 50s or early 50s, and somebody has already done an MRI scan, and a lot of these degenerative knees tend to have some degree of mucoid degeneration of ACLs and mucoid cysts in their ACLs. So I feel that it is a part of a degenerative process. Now, whether it is a traumatic event which caused it or whether it is a series of small degenerative events, it's difficult to know because by the time they present, things have already happened. I think it's only the ones which are symptomatic, they need addressing. If it's a definitive cyst and if it's in a location where it is obviously blocking flexion or extension, they're easier to uh, uh, be pinpointed as the cause of symptoms. But sometimes you have a patient in whom this might be a finding, but they may not have uh, uh, obvious flexion or extension blockages. Sometimes, if they are ganglion cysts, the musculoskeletal radiologists are able to do a aspiration under ultrasound. That way, we can avoid anesthesia and surgery altogether. But yes, the thicker cysts, it's difficult to aspirate, especially if they're causing stiffness, inflection, and extension. Then they need to be dealt with as you have rightly dealt with.
Asymptomatic cyst need not be treated, correct?
No.
Okay.
So that's what I'm saying. Because of so many MRIs being done, a lot of patients
Yeah.
just, they come to us with these cysts and mucoid degeneration. And most of the times the symptoms are because of a degenerative joint disease. And it's difficult to convince them that.
Thank you. Thank you, Nikhil, and thank you, Shradha. That's an entity really, it's an eye-opener for me that when patient comes with FFD and you don't find any other cause, at least do an MRI to look for the cysts and all. Thank
Or
you.
sometimes there's a cartilaginous loose body. So
Yeah. That's a good, yeah.
fantastic.
So thank you. We have run out of time. It's almost 9:18 now. So thank you all the presenters and all the moderators, Dr. Rajeshwar, Sidhu, Dr. Vidyanand Raut, Dr. Deepak Garg, Dr. Manit, Gundavda, Dr. Shradha Kulkarni, and Dr. Nikhil Gokhale for devoting your time to the evening towards cause of academics. And we'll again meet in 2 weeks' time with another set of presenters. Now, thank you, OrthoTV, for and Rishi, Dr. Our friends from OrthoTV for your help today. And have a nice evening. Over to Dr.
And I also, hello, I also take, can I speak something?
Yeah, please.
I also take this opportunity to wish Dr. Mohanty best of luck.
Thank you. The elections are around the corner, 20th September to 30th September.
Yeah.
Okay. Thank you, Vidya.
Yes.
Over
Best
to
of luck,
Dr.
sir. Thank you so much.
Thank
Thank you,
you.
sir.
Over
Thank
to
you.
Dr. Deepak Gautam for concluding remarks.
Thank you all. It was a great evening. Thanks to all the speakers and the moderators who gave this evening a time. So we'll be back again after 2 weeks, the same time, Wednesday evening, 8 to 9, with a new topic, new subspecialty in orthopedics. Good evening to you all.
Bye-bye.
Thank you.
Thank you so much.
Sir.
Rishi,
Thank
you
you,
can
sir.
stop. Stop spin.
Bye.
Bye, Vidya. Good night. Bye, Shradha. Good presentation, huh? You presented it very nicely. You have prepared it. So